Yeah, so donor preparation, I'll be showing my way of doing donor preparation. Normally, as Elmar was telling that in US, 80% of US surgeons use iBank prepared tissue. They always, Tony used to say that they are spoiled. And in fact, there is a good lecture I have heard that EK surgery in US starts in the iBank only. But nowadays they have luxury to have pre-strip, pre-stamp, pre-strain, pre-loaded, everything ready-made coming in this kind of pack. And they just take the thing and do the recipient preparation and transplant the graft. But India, all surgeons actually prepare their DMEK roll, and probably the damage during donor preparation is between 1 to 4 to 5%. So there are many techniques of doing donor preparation, like classical manual peeling technique, starting from trabecular meshwork or a prefixed refined cut, then scuba technique, the pneumatic dissection, reverse big bubble, like people are using for PDEC surgery, then hydrodissection and lamellar dissection. Last year, this was published by Tan et al. I prefer classical manual peeling with ripen blue assisted. It gives me better visibility. I need this kind of instrument, and stamping I used to this, and this regular tape lumbar, the hole is sealed actually, so it retains, it doesn't leak the trypan blue into the field, it keeps. So I prepare the tissue just before donor insertion, after doing PI of the recipient, and that time I give air tamponade, which is there for 5 to 7 minutes. This tamponade actually basically helps in two ways. One is it stops bleeding for PI, and it clears the edematous cornea to some extent. This is my experience, and it also saves time. And this is the air fill 5 to I prepared this graft. My technique is like you have seen, so it is just like a 9.5 or 10 millimeter. Our corneal diameter is little lower, so I use 9.5 diameter. Then I remove the peripheral DM. Then I, with the help of McPherson, I just leave the edges of DM. Then with single hand, I just peel the tissue towards like 6 o'clock to 12 o'clock position, and then put a stromal punch of 3 millimeter. Sometimes it hinge. So that hinge actually gives a good look, but it is more stromal tissue, then you have to cut it. Otherwise, it sometimes gives mess. Then S mark, flipping the block. Then 8 millimeters is standard diameter. I remove the peripheral DM, and this is the donor graft preparation, trypan blue staining, and then shifted to the petri dish, and now ready to put it in injected system. So with this technique, I have published my result. The average mean time is around 7 millimeter. So I have used both MK medium and cornisol preserved media. So 7.5 millimeter, though maximum may be up to 17 minutes. And my maximum graft size is like 8 millimeter. And so my data till yesterday, I was checking my data. So the donor tissue loss is only 0.6%. And this is the different kind of, I tried to say that because the peripheral endothelial cell count are more, this is now established. And you see the corneal endothelium is like that, more cells in the periphery. So during in situ collection, our technician actually gives 2 scratch marks at 12 o'clock position so that we could identify the superior cornea. So nowadays we are trying to do this which is DMEK PD, like 2 superior mark. Then this is the graft. After the graft preparation, you see that it is much more eccentric, like this side, superior side is 1 millimeter, and from the inferior side it is right 3.5 to 4 millimeter. So it is peripheral refined gut. If you compare with the central refination, and it is perfectly centered, but here it is eccentric. So my intention is trying to give more. So you see that same technique, only thing I am going in the periphery. So with this, you see that after mark, so when I peel the tissue, you see that from one side to other side, there is a lot of, so I am trying to go as eccentric as possible. So this is after graft, and you see the measurement when I take, it is 1 millimeter and 3.5 millimeter. And we have published our data. So this is the one same patient. I did one in 2016. That time actually it was accidental. I go back to the video and I saw that it is peripheral. And this was in the 17. And you see the difference in the cell count after 3 years, and the two eyes are different. Then during the COVID time, so we have acute shortage of tissue. Now I have changed a little bit of the graft preparation, so that my intention is use the anterior lamella, because we are giving anterior stromal punch. So we cannot use that for whole anterior lamella for other purpose like DAL, therapeutic or tectonic large, or as a K-pro carrier. So this is the recently, not is then stripped off. Not every day I am doing this. Not every day I am this. Only difference is that I have to lift the edge all 360 degree. So this is the new difference. This is a delicate instrument only to lift the DM endothelial complex, and the peeling technique is remaining same. No other instrument is required except you require a one regular bandage contact lens, and it has to be resized, because when I take the whole bandage length, the air trapping was difficult. So I made it 12 millimeter size, then make it a central hole. My intention is, without changing my surgical technique of putting S mark, many people are doing without mark. I am not that confident of doing, and mostly many people are advanced cases. So I put this BCL in the interface, then the rest of the procedure is almost similar. So they floated the endothelium complex, then peel that hinge part. That is important in this. And then after that, you just change it. Then you flip the BCL only, then put S mark. And the second, you have to punch in the second Teflon block, not in the same, in the, you just transfer the donor in the anterior lamellar cup and then stain it, and it is now ready for. With this technique, we could save at least 10% of our tissue, and now last year our utilization rate is 103%. So we use almost 47 eyes, and half of them are like tectonic and therapeutic, and also for DALC. So take home message that DMEK preparation, it is not, now we feel that it is not so difficult. Sorry, for initial cases, need some backup tissue, and use any type of media, MK medium, cornisol and Optisol GS, and try to take help from the master, watch some YouTube video, and it is always thrilling and with some adrenaline rush during this donor preparation. Thank you.